Hello, everyone, and thank you for joining us for today's discussion, Preventing Clinician Suicide, Going Beyond Resilience and Overcoming Stigma to Care for the Healers. My name is Rick Brown, and I'm the Senior Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training, and if you have any technical issues during today's webinar, please reach out to me or my colleague Josh Chung for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to help transform communities to advance access to quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support the healthcare workforce caring for America's underserved communities. We invite you to learn more about us and membership with ACU at clinicians.org. If you're interested in more resources on suicide prevention for patients and clinicians alike, we also encourage you to visit our Suicide Safer Care page, where you can find a variety of resources, including fact sheets, toolkits, archived webinars, and much more. I'll ask my colleague Josh if he can put the link into the chat, but you can also scan the QR code, which I'll leave up for just a moment. Okay. Before we begin, I just want to go over a few quick housekeeping items. First, we will be recording this session and we'll share the recording with attendees within a week of the webinar. We also encourage you to ask questions as you think of them via the chat, and we'll have a dedicated section for Q&A at the conclusion of the session, which will end today at 2:55 p.m. ET. Please also complete our evaluation at the conclusion of the training. It's tremendously helpful to help us continue to improve the quality of our programming. Lastly, I am honored to introduce today's distinguished panel of speakers. Verna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior VP for a large FQHC network in New York. Eileen Barrett is an internal medicine and addiction physician based in Albuquerque and president of the American Medical Women's Association. She received her MPH from the University of North Carolina at Chapel Hill and her MD at Georgetown University. And she completed a medical justice and advocacy fellowship through Morehouse School of Medicine and the AMA. Her writing has appeared in the Journal of the American Medical Association, Journal of Addiction Medicine, Journal of Hospital Medicine, Annals of Internal Medicine, Modern Healthcare, the New York Times, and more. Chris Weinar is a psychiatric mental health practitioner, suicide prevention strategist, vice president of United Suicide Survivors International, and founder of Empowered Psychiatric Solutions. He specializes in integrating zero suicide aligned practices into healthcare systems and advancing policies that protect clinician well-being. Drawing on lived experience as both a suicide attempt and loss survivor, Chris focuses on addressing the structural, cultural, and regulatory factors that heighten suicide risk for health professionals. His work spans clinical care, research, and organizational strategy, helping institutions build compassionate, stigma-free pathways for intervention, prevention, and postvention across the workforce. We are honored to have each of them today with us, and with that, I will turn it over to Dr. Little to kick off today's discussion.
Thank you so much, and thank you to the speakers who are joining us. Thank you, everyone. We so appreciate your participation, and as we were preparing to speak today and sort of having some discussion, it is both I think surprising, well, heartbreaking at the increase in suicides we're seeing in care providers, and this topic continues to grow. One of the things that we were saying is that it's really hard to be able to know just the extent of the problem. And so what we're hoping to do today is to have some good conversation, to be able to answer some questions and have some good discussion at the end, and really hear from our guests today about what they're seeing in the field, what some of their thoughts are, and most importantly, what we can do to try to impact and try to bring some change. So I think I'm gonna start, and let's just kick off a little bit to both of you and just ask, and maybe we'll do Chris and then go to Eileen. Tell me a little bit, what do you see as the scope of the problem? What do you attribute some of the elevated rates to?
Oh, thanks, Verna. I think the big picture is that clinicians are not at higher risk because we are weaker, but because of the conditions that we work in. Large workforce studies show that nurses, health technicians, and healthcare support workers in particular have higher suicide rates than many other workers. The patterns behind that are pretty consistent. It's chronic overload, moral distress, violence from patients and families, sleep disruption, and access to lethal means, and a culture that tends to punish mistakes. Those all drive despair. And when you put that on top of personal factors like trauma or depression, and then you add an activating event such as like either a complaint, a lawsuit, or job loss, it can quickly move someone from thoughts of suicide to action. So this is really an occupational safety issue, not an individual resilience issue.
hmm I want to stay with you just for a moment, Chris, because I I'm not sure we had as much attention to the suicide crisis among nurses. And there was a fairly large study a couple of years ago that really brought it out and sort of brought the problem to light a little bit. Maybe you could just talk. I think that was like early 2021, like somewhere a couple years
Yep.
back. Yeah.
Yeah, and that research really started at UC San Diego with Judy Davidson and team, and even dating back to like 2017, 2018. So at least for myself and my personal lived experience, in 2018, I reconnected with a childhood friend of mine who also was a nurse with me at my hospital, and we reconnected like time never passed. He played bass, I played guitar. We were talking about getting together, getting the families together, and then he died by suicide in August of 18. A week before him, we lost another ICU nurse at my hospital. From August until 2018 till December of 2018, we lost like 6 or 7 health workers just in Wisconsin in our health system. So really, that led me to the research that Judy and team was doing, and the most, how it is, trying to get a good handle on how many particular specialties or clinicians we lose has been very difficult. I mean, even on a national level, trying to get suicide statistics is kind of difficult for various reasons. So let's say a nurse does die by suicide. That death has to be coded as a death by suicide. And then some municipalities, they don't even have processes in place for who actually puts down the occupation. So medical examiner sometimes does, sometimes the funeral director does. Sometimes they leave it blank, or sometimes they use variable key terms. So when trying to really get a handle on how many nurses, what we know so far, and I think it was back in 2021, maybe 2019, is that 759 nurses die by suicide every year. Based on the trajectory of things are going, I think it's safe to say that probably 1,000 every year for nurses in particular.
Mm-hmm.
And
Dr.
besides,
Barrett?
and behind each of those numbers, is obviously a person, a family member, a husband, a wife, a spouse. So I just wanted to mention that.
Yeah, absolutely. Dr. Barrett, what are some of your thoughts about, how did we get here in terms of scope and maybe some of what we're learning?
Yeah, thanks. And please feel welcome to call me Eileen, but do what you like. A lot of the factors that, let's see, I don't think, first I should say, I don't think that I can say it any better than Chris just did. What are the drivers? What are the contingencies? What are the complexities? Actually, I'm quite sure that I could not say it any better. And that how we got to where we are, maybe 2 additional components. One of them is just that in general, societally, that this is something that we don't talk about, that families often feel a deep sense of shame or guilt. So then that is something that we can't separate ourselves from as healthcare professionals, right? Which is that we are going to be affected by whatever is happening societally. Another feature that we have is that the data processing is difficult, that also one has to, within our profession, if one is going to also be reporting that there has been one of our colleagues who has died from suicide, that there also has to be, and there always should be, deep respect for what is their survivor's preferences, and that might not always be what their surviving loved ones want to have shared, for an assortment of reasons that, of course, none of us would ever judge them for. And I think that regardless of where we are with the absolute numbers, I think we can get hung up on the numbers because we're really perfectionist-oriented people, but the most important thing is exactly what Chris said, which is these are people, and that I think we have as part of a moral community, we have a real duty to strive for a zero suicide model, and to not stop until we reach that, which I think we will be able to achieve if we bring our collective wisdom and also our collective will to the challenge.
Well, I think it's important, even now having done some of the zero suicide work for quite some time, people still ask me, well, like zero, and still often have the conversations to say, well, what number would be okay? Like, we know these deaths are preventable, like zero. We go for zero in other measures in healthcare, right? Like, why wouldn't we strive for zero when we're thinking about suicide and suicide care? So certainly, I'm wondering, as we think about what particular stressors might be for healthcare providers, talk a little bit about loss of licensure or some professional implications that may play a role. And maybe Eileen, kick us off with some thoughts, because I'm certain that that probably is a factor.
Yeah. And I'd love to hear what Chris will be able to share when I'm finished. So it absolutely, there's been a long history of anecdotes, but there also has been a body of literature that shows that particularly that physicians have been very well studied here, but it also has been the case the nurses have been too. There's less literature about pharmacists, about social workers, about the rest of our interprofessional team. That's not okay. I have no reason to think that they wouldn't have the same concerns that my peers in medicine do, right? But that there's a very real fear that if someone seeks care, or if they even have a diagnosis, that they could lose their license. And that fear was not unfounded. They weren't wrong, because there was a long history of when someone had even just had a diagnosis of a mental health, of a non-impairing mental health diagnosis, right? Or receiving care, or even if they could have reasonably considered to have had a diagnosis, i.e. they didn't seek care because they were afraid of getting the diagnosis, but they might think that they do have that depression or anxiety, that they could, disclosing that in the process of renewing their license, their licenses that allow them to have their professional livelihoods, oftentimes their identity, right? That it would trigger an extensive investigation, much of which would be made public. And so that has been a tremendous challenge. And what is also a story of hope, which is that there's been a sea change in how our licensing agencies have looked at this in the last several years. There was a paper that came out in the proceedings of the Mayo Clinic. Christine Sinsky was one of the authors, who is most, and also Lisa Derby, that this came out in about 2017, where what they did was that they collected all the medical license applications from all the states across the country, because of course there's state-specific licensure. And then they also surveyed physicians across the country. And then they corresponded, well, how often are they asking about if you have a mental health diagnosis, or anything that could get at that, to how likely would you be to seek mental health care if you thought that you needed, and found that people were not seeking the care. And that work, and then some other work I know it has made some serious headways here. I co-authored a paper in the Annals of Internal Medicine in 2020 based off of work that we did in 2018 and then completed in 2019, where we changed our medical license application to, it had been this 5-year look back of if you even could have had the diagnosis, to one that just asked about impairment. And we published in the Annals of Internal Medicine because we wanted other people to learn from our experience. And then South Dakota picked it up, some colleagues in California, and it ended up later on in Florida, also some colleagues in Wyoming and Arizona. And then, of course, quite famously, that the Lorna Breen Foundation stepped in here to do some pretty remarkable work, how they have scaled this effort. My full disclosure is that I was one of their consultants. I don't get a toaster if you use one of their amazing resources. Please use their resources to make this sort of a change. And what we have found is there has been a sea change of progress here, and two things remain to be true. One of them is people still think that it's a problem. So even though it is not, they still perceive it to be a problem. So there's more work to be done. And also it just brings us humility that we can fix a process, but if we don't over communicate it, then we haven't really fixed the issue. The second thing is that even though this change has happened, the problem persists. So it means, again, that there's just deeper work to be done. I got a little bit in a soapbox there. I'll pause. I'm excited to view myself and to hear from both of you.
hopefully also to fuel the professional appointment process as well as the licensing applications. Like, I think there's been some great efforts in both, and I think we're not anywhere near where we need to be. But I know at one point I sat on a professional appointment committee for an organization, and it was really oftentimes I just was really heartbroken for folks that I know would have been wonderful providers, and the professional appointment process. I can't imagine what that experience was like for them. But certainly turning it over to you, Chris.
Oh yeah, thanks. No, and again, I can't say it any better than Eileen there. And what I will say too is I'm a volunteer ambassador for the Dr. Lerner Breen Heroes Foundation. So just to say that as of September 19th, 2025, 5 dental licensure boards, 40 medical licensure boards, and 6 nursing licensure boards, in addition to 9 pharmacy licensure boards, all verified that their license applications do not include intrusive mental health questions. So that benefits nearly 2 million licensed health workers throughout the nation. And I think, I see stigma and licensure fear as accelerants. I think many clinicians are frightened that if they do admit, again, in most states, even the laws when it comes to defining unfit to practice, a lot of laws will say that even having a diagnosis of some kind, including like a substance use disorder, like I've had attorneys for state agencies say that having a diagnosis of substance use disorder is actually considered unprofessional conduct, and it's not even a focus on like functional impairment, right? So I think these states that do have these archaic laws, I think that's where we have to have a big impact as well. But I want to touch on just that the perceived fear and real fear, right? And what actually happens. And I think that when clinicians are navigating these types of processes, that a lot of powerful cognitive distortions happen. And under stress, the brain's threat system is lit up, and the story becomes, if anyone finds out, I lose everything. My life is over. Everything that I worked so hard for is now, gosh, who am I if I'm not this? And I think that drives secrecy, self-medication, and avoidance of care. So in the research, it's been clear that job problems and disciplinary action continue to show up again and again in the histories of clinicians who die by suicide. So I think stigma and punitive systems are not side issues. They directly shape the moment of crisis when someone is deciding whether to reach out for help or if they see death as the only way out.
Mm-hmm. So one of the projects that ACU works on that I have the absolute pleasure of being a part of is a training for primary care organizations around how to identify and care for someone at risk for suicide in a routine visit. And I think now we've trained over 4,000 primary care providers in their teams in like 34 states over the last couple of years. And part of that project meant we had to go to a lot of residency programs and medical schools. And one piece that I was touched by and sort of talk about often is in that work, I never went to a residency program or a medical school where someone didn't come up to me and tell me about someone that they lost during school or residency. Not one single time in any school or any residency program, pediatric family med, like it didn't matter. And I'm wondering if both of you could talk about sort of your experiences with losing a clinician to suicide, a colleague, or perhaps even your own experiences.
Chris, do you want to go first, or would you like me to?
Yeah, no, I can go. I kind of alluded to this a little bit before, about my close childhood friend and colleague. And I think being in this work and this is what I talked about at the International Zero Suicide Summit in Liverpool a few years ago, is that what I had somebody tell me, my close mentor, colleague, Judy Davidson, tell me is, Chris, when getting into this work, make sure that your suicide safety plan is up to date. And she said, you don't have to show it to me. You don't have to, just make sure that you got everything squared away for yourself. And I think that was a shift in thinking, because when we do get into this work, and we know that postvention is prevention, which I'm sure we'll talk about later, but even us who are doing the work and having impact, we're also impacted by those that we lose. And I think it wasn't until my daughter, who obviously isn't a clinician, she'll be 18 on Christmas Eve, but it wasn't until she attempted suicide when she was 13 where I was like, man, okay, I'm a suicide attempt survivor. I went through this stuff. Like, I'm pretty knowledgeable. I wasn't quite a psych MP yet, but how could I have missed this? How could I have, not seen these? And I was going through a lot of the same questions and things that that a lot of people go through, just in the general population. Even with my friend, it was, gosh, I did notice some things that were wrong. Maybe it was just a little different, and really going down those paths of like asking whys. So I think even us doing the work, mental health clinicians, mental health professionals, I think what we do after an event happens, even when I contracted with the eating disorder clinic for child and adolescents, when you have an adolescent attempt suicide or have a near miss, I think a lot of times the support that clinicians desperately need is not there. And we can do a much better job with that. I think, and so, yeah, that's just what I kind of allude to, but yeah, I've lost a number of people to suicide, and that's been the driving factor as to why I'm doing this work, to turn that pain into purpose.
Yeah, suffering ceases to be suffering when we can find meaning in it, right? So that's most of, I think everybody I know who does this type of a work to reduce barriers to clinicians or anybody receiving mental health care is because we know somebody who something terrible has happened to. And we hope that nobody else ever feels the way that we felt when that person who we love, we admire, we trust, or that we barely knew, but that they were a person, that their night was so dark that they didn't know that, the night is darkest just before the dawn, and that the dawn was actually coming. So I am also somebody who, that is how I got to this work, is thinking this is a solvable problem. And that actually, maybe I can best capture it, that when I was at a meeting and they asked us to raise our hands if we had known anybody, if we had known a physician who had died from suicide, and about 3/4 of the room had their hand raised. And then they said, and if you've known more than one, if you've known two, and then they just kept on going up. And I was one of the people who kept my hand up for 4, because what we were trying to do is humanize, of course, and to understand, like, you are not alone. And of course, that is why you're here. And that is why this is why you care about this, and why people who do this work, why we are relentless. And also, I think, why we see the infinite possibilities for the options. So, like, say, for example, one of the things that I was hearing and or thinking about, Chris, when you were speaking, was about my own experience after one of my, actually, maybe I have like 2 of them to share. And one of them is that after one of my colleagues died from suicide, like the day after, I said, I sat across from him and said, are you okay? Is everything okay? Something seems off. Is everything okay? And he was so reassuring to me. And how that made me think very, very differently about what I wanted to do as a colleague and also as a boss. And then how I started to think about what is the way that we can take care of each other differently and take care of each other better and reduce barriers to people being able to receive their mental health care. And then also, when one of my learners, meaning one of my residents, died from suicide too, that just what do we need to do better so that this can never happen? And it was specifically also the loss of a physician that led us to change to let us do this successful advocacy that led to our state changing our license application, so that then we could write about it, so then we could cascade it for other people. And then also taking that to scale to, like you said about credentialing, that then I was able to lead a national coalition through the Institute for Healthcare Improvement, who said, we believe in this too. And we're able to work to revise the questions for, I mean, one system alone was 140 different clinics and hospitals. So the work goes on. I think I kind of went in a different direction here. And I think that maybe 2 things that I'll say that this made me think about is every time that there has been a loss or hearing about a loss and thinking about, well, what else does the literature now show that we can do? And also, even if it isn't suicide prevention, but if it is effective at some other meaningful measure, it is still worth doing. So say, for example, some people know that in the Journal of the Journal of Graduate Medical Education, that there was a paper that was published about a residency program in West Virginia that had done opt-out mental health care for all of their interns when they came in, and 91% kept the appointments. And what they found over time was that they also had fewer professionalism concerns. And I think of this because I think of how Chris just described, when these like professionalism issues come up, we should consider that an urgency, like not for the care of our members. How do we lean in further to our compassion? What degree of support does this person need? Because this might be their way of telling us that that things are becoming untenable for them.
Absolutely. And I think if we were gonna, think about a shift to organizational change, we sort of been talking a little bit about, the credentialing process and others. One of the trainings that ACU does is sort of helping organizations think about change that will support both suicide safer care on the consumer patient level, but also organizational preparation. And some of that is postvention work, some of it is prevention work, and really putting together some solid plans around suicide in the organization. What training are we giving our managers to know warning signs, to ask questions? What language do they use? I remember when I worked in health centers, we would spend an inordinate amount of time doing something called a hazardous vulnerability assessment. And I remembered the sheet had it was a big sheet, and we had to come up, and we would come up with these things like, well, what if a subway train came off and went into the health center? And then one day I said, wait a minute, what if we actually put suicide there? What if we put suicide and, losing one of our providers to suicide? And it really changed the conversations in the organization, and making suicide care and prevention part of that process allowed us to have lots of different discussions across the organization around appointment, around hiring, around response, around onboarding and management training. And I think that's the kind of organizational change that we need to start to inspire. And so I'm wondering, for both of you, and maybe starting with Chris, what are some thoughts about organizational change and some of the workforce strategies and workplace strategies around suicide, safer care and prevention?
Yeah, and I think I want to take the audience and you all kind of on a storytelling journey a little bit. So imagine a clinician. His name is Jordan. He's a 39-year-old, let's say, ICU nurse. All right. Worked his way up through school, juggled kids and night shifts, passed boards, got critical care certification, became that go-to person for complex patients in the department. Over 10 to 15 years, Jordan accumulates just constant exposure to death, trauma, moral distress, short staffing ratios, unfamiliar units, several episodes of workplace violence from patients and families, a culture where speaking up is seen as distress or sometimes even complaining. The internal dialogue starts to turn to, well, their worth is equal to productivity or heroics and never making mistakes, right? We're all superheroes. So over the last year, Jordan's dad dies and his marriage gets strained, and they start staying late, picking up extra shifts and drinking more after work. Sleep falls apart. They feel numb at work and irritable at home. And then there's a precipitating event. After a brutal stretch of shifts or a serious near miss on the unit, Jordan drinks heavily at a friend's house, decides to drive home, and is pulled over and arrested for a DUI. Hospital policy requires self-report, and the state board is notified. Human resources is alerted, and that internal narrative, Jordan, is my life is over. I am nothing without my license. If this becomes public, I would rather be dead. Now, I think there's 4 different worlds, but I'm just going to talk about the poor response, and I'm going to talk about the best response, and you'll be able to see the difference. So in the poorest response, in the poorest world, I think everything would be fragmented and punitive. So at the hospital, Jordan, get a generic email from HR telling them that he's suspended pending review. No one explains what will happen next. They're told to contact EAP, right? Here's a card for EAP if needed. Their manager is kind of anxious about liability, so stops texting and tells the coworkers, I can't talk about it. Gossip kind of fills the silence. No one is assigned to check in on Jordan as a person. There's no suicide risk screening for staff in this situation. At the board level, the board sends a long legalistic packet asking for a lifetime mental health and substance use history, all treatment records, and a narrative of the DUI. The forum questions ask about ever having a mental health condition or ever being hospitalized without focusing on current impairment. And then Jordan learns that their name and order will be posted publicly online if discipline occurs, including details about substance uses or diagnosis. And of course, at the EAP level, what ends up happening is that sometimes at the poorest level, EAPs, sometimes they don't even have, they have generalists, counselors who sometimes have no specific training in clinician suicide risk. And the clinician asks if Jordan is suicidal, and Jordan gives a vague answer, right? There's no structured suicide risk assessment, no safety plan, no lethal means counseling. And he gets 3 to 5 sessions focused on coping skills and are referred to find out their own long-term recovery, right? On their own time, own dime, own dollar. Meanwhile, he can't pay for it because he doesn't have a job. He's suspended. So I think the message that Jordan receives is that you are a risk and that this is about compliance and protection of the institution. And that if you fall apart, that's on you and risk goes up. The DUI, possible job loss, and shame feel like proof that their life is over. They drink more, isolate, and ultimately Google clinician suicide or ways to die, at 2 a.m. Now that's the poorest response, right? Now, if we go to the best response, this would be the ideal. And this is the intentionally designed version. And this is kind of a granular how-to. I think it would start with pre-work before Jordan ever even got a DUI. The organization, EAP vendor, and board have already done foundational work. They've adopted zero suicide principles for both patients and staff. They have all those pillars: lead, train, identify, engage, treat, transition, improve, explicitly including health workers as a priority population. They conducted a policy review with HR, legal, and lived experience leaders to remove that stigmatized language and align with ADA, American Disability Acts. They build a confidential clinician-specific support program that may be in-house or contracted with providers that are trained in suicide risk, moral injury, and licensing fear. And they create clear written protocols that when staff are involved in high-risk DUI complaints or inpatient stays, do this. When someone discloses suicidal thoughts, do this. When a clinician returns from psychiatric hospitalization, do this. And they have trained leaders and peer supporters in basic suicide prevention skills for colleagues. And that's how to notice, how to ask, how to listen, and how to warm handoff. Now, that DUI could still happen, right? And the best case pathway would be is that human resources would receive a notice of Jordan's DUI, a mandatory self-report requirement. But the first step would be immediate and humane outreach. So within hours, a designated clinician support coordinator would call Jordan. They introduce themselves not as compliance, but as I'm here to support you as a person through this process. They explain what will happen procedurally and explicitly say your safety and well-being are our priority, not just paperwork. And they ask permission to connect Jordan to internal clinician support programs. Now, there's also suicide-specific screening and assessments that are involved, as well as with structured safety planning. And ultimately, I think what it really comes down to is that that warm handoff, if needed, it goes to ongoing care, and that ultimately there's an integration with human resources and occupational processes. And I know I've taken up a lot of time with this story, but I think overall, I think the best is that the hospitals overall and the systems, that we're treating people as humans, as dignified humans, and we're having the systems in place to address these things. And I think organizations that have zero suicide for staff in early form, I've always been a proponent of taking zero suicide and applying it into health systems. I think that could be exactly the thing that could help in this moment or in these moments. Thanks for following me along that little storytelling journey.
That was a wonderful example. And I mean, as you were going, you could really envision the different experiences that, that individual was having. And so not only saving lives, and changing a trajectory, but just changing that whole experience. And I think that's some of what organizations need to do, and thinking about some policies, like you brought up the EAP programs, and I will routinely ask organizations, one of the things you need to know about your EAP provider or choosing an EAP provider is what is their training around suicide care? Have they adopted the zero suicide model? Do they have, trained clinicians? What is it that they have foundationally for suicide care? And oftentimes what you find is exactly what you described sort of in scenario one. And I think organizations have a tremendous opportunity, even in some policies, for example, people who may not come to work and may not call. We sort of say a no call, no show is the common language there. And after 3 days, you get a letter in the mail saying that your employment is terminated for abandoning your role oftentimes. And, the process to even call and just ask someone if they're okay, I think is sort of one of those very easy policy changes to make that can dramatically change someone's experience, but also change the culture of an organization in terms of how we care for each other. I'm wondering, Eileen, if you could talk a little bit about maybe some other organizational changes or even some thoughts about how we can train managers to be able to respond and the ability to maybe pick up on some warning signs.
Yeah. Well, I mean, when we hear about option, but scenario one versus scenario four, as we just saw, scenario four is what everybody deserves. And that also takes us time, organizationally, it can take us time to get there. And sometimes when it takes time to get somewhere, people can feel like maybe I'll never get there, so it's not worth doing. And I think what we could start to do is maintain our high standards, exactly what you just heard. Like, we are relentless in so many other dimensions. We are relentless in our billing and coding. Let us be as relentless in our commitment to that trauma-informed, evidence-based model that we just heard Chris describing, right? And so what we can do is think about, well, what is this something that is within my power that we might be able to just start with? So one thing that we could do, which is a model that's already out there, is we can even just start with, how about we're going to support all of our managers in getting mental health first aid training. That is like just that is like low-hanging fruit that we can achieve, right? That is big enough to matter, small enough to win. We can also, even if that's like, well, that's going to take some time because it is an 8-hour training, right? Even though it's evidence-based and we believe in it, but like, well, maybe right now we can't exactly get to that. How do we make the case for it? Well, maybe we just start with that we invite Chris to give our grand rounds, right? Or we invite you to give to talk about, well, who can we be, right? So we choose the things that are big enough to matter and small enough to win. So that's what I would ask all of us to keep in mind, that there is something like that. So you heard me mention mental health first aid. I think that there's also invaluable benefit to considering looking at things like, say, for example, let's just call something mental health days. Where I work, we actually, when you find out what is your benefits package, they includes that everybody has 2 days for mental health days, and they specifically call it that. And it also doesn't carry over from year to year. So it's like the please use it. There is no award to the person who doesn't use it, but also it is very important to communicate, this is how much that this specific thing matters to us, right? So that's low-hanging fruit. There also is ensuring that we collaborate with our EAP. As you heard, there's a lot of them. There's a range and experiences that people can have, and that we can choose to be we can choose to maintain our high standards with what we want there. We can also do things like what is the care that we can do tomorrow so that we can make it so that we will work with insurers so that there will be no copay on someone receiving mental health care. Or we as an organization are going to cover it if there isn't an insurance company or in our menu of options that are available, that we that there isn't an option that has no copay. But maybe organizations figure this out. I'm not a lawyer, but I know that they figure it out. I think I went slightly in a different direction that you were talking about there, but I think you can see why I went in that direction, because just to highlight that we can all get to everything that Chris described, and I want us to be there last year. And let's just start tomorrow. The idea that what can I do? I'm just one person, said 7 billion people, is let's be the people that Chris is describing.
I love that. And I think I, certainly have been a huge supporter of mental health first aid. And oftentimes, we can train or talk about some very basic things that we can do for some of our managers or our team members, including what I like to call storage statements. So things that we've thought about ahead of time that we might respond to someone who told us they're thinking about suicide, and then we are prepared, and we can practice at staff meetings, we can practice at the dinner table, we can, practice at night when we're brushing our teeth. I always say, thank you for telling me you're thinking about suicide. Your life is very important to me. So giving people some language that they can use oftentimes is incredibly helpful, so that if someone is sitting at a lunch table or sitting at a front desk, and a colleague, makes a suicidal statement, or they're concerned about someone, that they have language. So I want to try to give each of you some individual questions. So I know, specifically to Chris, we've talked about some barriers for clinicians receiving help. Maybe just talk a little bit, these barriers are sort of at all levels of the organization, right? You see them. How do we we've talked a little bit about closing some of the gaps, but what sort of very practical advice would you give to people on this webinar? I always think what's really helpful is what can I take back and do right away, right? Without sort of changing organizational policy. What are some ways we can start to close those gaps?
Oh, thanks for that. One of the most hopeful things I can say is that two organizations, that we don't have to start from scratch. I mean, the national guidelines for workplace suicide prevention and postvention, that entire committee, co-led by Dr. Sally Spencer Thomas and Jody Fry, I mean, they've developed 8 or 9 evidence-based best practices for the workplace in addressing mental health, suicide, and prevention and postvention. And that's www.workplacesuicide.com. But they actually also have HR and employment law white paper that talks about 13 fears that organizations often have, that are sometimes just complete their fears. I mean, they're not based. They're not. I don't know. I wouldn't say they're not real, but that they're fears that prevent organizations from doing the work. So, and I think what those best practices really point to is first is visible leadership commitment. And I think that having that organizational leadership commitment can sometimes be the hardest thing, but when it's there, my gosh, does it make a difference? And that's naming suicide prevention as like a core safety priority, and mental health as a core component. You hear about all these well-being programs that are happening, and well-being has really taken a big lift off, over the last years. But none of the well-being programs are really addressing mental health, substance use, or suicide in the workplace. Where do we spend most of our time? The workplace. So, and I think even from policies, and as you mentioned too, Eileen, is if you're doing 8 things kind of good, you're really not doing anything good. So try to focus on very specific things. Maximum of 3. So let's say, for example, if you're trying to look at policies and align those policies with best practice, pick 1 or 2. If you have a fitness for duty policy, or leave of absence policy, like take a look at that. If it's a performance management policy, or like a return to work, just pick certain things and really focus on that. And I think building those clear confidential pathways to support, especially including peer support, I think those peer support is such a proven evidence-based intervention that I think we're already doing. A lot of people are already doing, they don't even realize it. So it's just how to provide those skills to be able to have them and peer supporters provide safe and safe for them, and also safe for the person who's receiving that care. So yeah, and I think I may have mentioned this, I can't remember if it was before or after, but I like to think of interventions as 3 different levels. We tend to go straight to the individual level, and that's usually the do more yoga, do more meditation, or do this. But if we just focus on the individual interventions without focusing on the organizational ones, then I don't think we're doing a good enough job. So. Yeah, I know the work is plentiful and there's a lot of it, and it can be very easy to kind of get, because change is slow. And I think change management is a big thing that I wish I was better at. But I know that some of the processes just take a long time, but I think just one thing at a time, and sometimes that's the way we live, and people have to survive, is just sometimes 1 minute at a time, 1 hour at a time, 1 day at a time, 1 week at a time. So
Wonderful. Thank you. I'm in sort of going, Eileen, on that sort of thought around organizational change. We talked a lot about, licensing, credentialing. So two-part question. What are some concrete steps that folks on our webinar today might leave this webinar and do that would start the process in their organization? And if they were interested in broader advocacy, what might they do?
Yeah, maybe for two concrete steps. The first one I think is to invest in yourself, in the ways that include to be able to sustain yourself for this type of work. So take good care of yourself. You cannot take care of anybody else if you can't. Well, actually, the thing is that we can, but we shouldn't, right? Like these two things should not be at odds. But part of that investment in ourselves, I think, is also investing in our communication and also our persuasion skills, and how to read a room and how to make the message be responsive to the messenger, because oftentimes we are in a time societally when we're doing more calling out than calling in. We're destroying bridges more than we're building them. And so that if we can invest in ourselves and our persuasion skills, and also just being even stronger listeners and being present for the other people's concern, that will help set us up for more success when we want to do the next thing. And the next very tactical thing with regard to, since you asked about licensing and credentialing, and to know a lot of the licensure work is actually really happening. There's a lot of people in this space right now. You heard about, Chris was talking about the Lord of Breen Foundation, the IHI is doing this, the American Hospital Association is doing this, the American Nursing Association, the American Medical Association, the Federation of State Medical Boards, the Federation of State Physician Health Programs. Like that one really, really is happening. So join forces with people who are already there. And also, when we see ourselves as change agents, when we sustain ourselves, when we invest in our change management skills, as we heard Chris describe, when we invest in our listening and persuasion skills, then we can also translate some of that locally, such as using the toolkits that are available, either through the Institute for Healthcare Improvement, through the Lorna Breen Foundation. There are probably others as well. The American College of Physicians has one. There's a lot that are good. Use the one that speaks the language to the people who you're working with. So if you have people who are very like, I'm really worried about quality, well, then use the IHI materials. It's IHI. If you're the people who are like, I'm there, I just don't know how to do it, and especially it means a lot to me to be able to get the peer recognition, go with Lorna Breen, because they will put your name on the map and give you the star, right? Go to the Lorna Breen Foundation. So those are maybe the broad buckets of two things. One, invest in yourself, and the other one is use the tools that are already available to you, that I think probably in a follow-up we'll be able to share with any meeting attendees.
Wonderful. So as we sort of prepare to go into a Q&A, one question I'll put out to both of you is, if someone, a supervisor, a colleague, someone is concerned about someone on the team, recognizes that someone is at risk, what do you sort of recommend for organizations to train as next steps, or for individuals to do as next steps?
yeah, I'd say usually the first piece of advice I tend to give is don't enter into these conversations without knowing your resources. And I think knowing your resources for when you don't need them, so they're there when you do, I think is key. And I think one of the approaches that I have found works very well is QPR, question, persuade, refer. So once notice warning signs, the key is to really be simple and human. And that 3-step approach, first noticing and naming what you're seeing in plain language. Sample language could be, I noticed you've been quieter, missing shifts, and you don't seem like yourself. Second is, asking directly about suicide, not dancing around it. But sometimes when people feel this is overwhelmed, this is kind of like the passive approach, right? Sometimes when people feel overwhelmed, they think about ending their life. Is that happening for you? Or just asking the question, are you thinking about killing yourself? obviously, and the audience, I hope, knows this, but the evidence is clear that asking does not put the idea in someone's head. It gives them relief that someone can handle the truth. And third, I think, is don't carry it alone. We know our leaders are pretty taxed with, I mean, I had one leader who had 130 delegates. I'm like, oh my gosh. So I say for leaders, try not to carry it alone, but know that stay with them, especially, if you're getting the feeling that there's an imminent risk and access to lethal means, and connect to help. Whether or not there's internal EAP, external EAP, or even 988. 988, I think, is, and what I love that 988 has done is they actually paint a picture of like what happens when you do call in, dial in, because I think a lot of people are like, okay, what happens when I do this? So I'm really happy that they started showing that, like what actually happens when you reach out. And I think supervisors and colleagues shouldn't be expected to be therapists, right? And I think there is a difference between support, compassion, and obviously trying to be a mental health professional, right? So I think keeping it basic is that their job is to notice early, have a courageous conversation, a compassionate conversation, and to make sure that person isn't left alone, especially if there's a higher level of distress. Those are just kind of basic higher level things that I would say.
Yeah, absolutely. 988, having someone put it in their phone along, having them call Now Matters Now website. Absolutely. Eileen?
I would just plus one to everything that we heard from Chris, and let's invest in each other today, because nobody wishes that they had this training or had this knowledge. Nobody wishes that they had it because they needed it today. Let's invest in people now. And the good news is that we always can. All of us can decide today, like, okay, we're going to invite someone to talk about, and we're going to add it to our skills building and how we invest in each other is how do we ask and not expect people to be the therapist, exactly as you just heard. We don't want to put people in, we want to give them something that, again, is something that they is important enough, and that also that they are able to master.
Wonderful. Well, thank you. So we have a couple of questions in the first one, and I'm sure both of you can relate. And I know I've had this question and this experience. Someone wrote in that they're implementing zero suicide. How would you, as physicians and providers, encourage other providers, hospital staff to engage in the zero suicide framework? So Chris, and then Eileen.
I lead with lived experience, and I think even just the storytelling that I did a little bit earlier, it paints the picture of what a process is like when zero suicide or when these evidence-based things aren't there, and the difference between the two. And I think this is probably something, Verna, that you probably run into, and even when approaching health systems is it's wild to ask the question, why not? Right? Like, why not? And I think what I've talked to people sometimes before is that even when you share like the reason why you're doing this is to prevent death, sometimes that's not enough for buy-in. It's like, so you have to, again, I think what Eileen says too is speaking the language of the person you're talking to. Obviously, if you're speaking, some language to a person that they just don't understand, or it's not only that they understand, but that it's pulling strings within them that's connected to their, whether or not that's intrinsic or, their motivators. I think that's huge. Like, I loved the fact that there was an economist that was at the Zero Suicide International Summit, because if you try to talk to an economist about, a heart story, they're like, no, I care money. That's my
Right.
widgets and whatever else, So I think, that's the most important thing. And ultimately, though, it's putting the trust in that framework, and the research is out there. I mean, Brian and team at Henry Ford, they've published the results on it. But again, sometimes even when the evidence is there, it's almost like we're trying to convince people that the Earth is not flat, and all those things that they went through. But I know it just it'll take, hopefully it won't take more death in order for change to happen. And as you said, Eileen, I think I would just encourage people to start saying, and I'm going to use that one too, is let's invest now, because yeah, it's really painful and unfortunate when you have to do it after the fact. I mean, yes, it is possible to turn pain into purpose, and I'm a story of that. Eileen's a story of that. There's a lot of different stories of recovery and healing, but let's be more proactive.
Yeah, I find it helpful to also point out that suicide is not different in that you already know what to do. You do some of the same. You ask questions, you get information, you figure out a path. If you're thinking about an asthma patient, you do an asthma action plan. Maybe you make a referral, you ask questions about the home, you do some education, like a lot of the same process that you might follow, you already do. And so how do we take what you need to do around suicide and plug it into those same workflows? And I think sometimes when you can make some of those comparisons, then they're like, oh, okay, I kind of get it now. So I've found that a little bit helpful, Eileen. I'm curious to hear what you've found to be helpful.
Yeah, a
One
couple
thing,
bits. Oh, go ahead.
one thing, I just before I forget, and it was, I think the biggest thing. Oh man, and I just lost it. Oh, it was there and I lost it. Sorry, I got it. I got all excited and stuff, and I was
Hopefully
like,
you're going to get it back. Yeah.
it'll come back to me. Oh, I'm so sorry for interrupting, Eileen. I
That's
apologize.
okay. Go ahead, Eileen.
You're great. You're great. So, yeah, I find that a huge thing is figure out what is almost like their love language and how to communicate that. So, say for example, I would think about, well, let's see, what I have used in the past, in the case of when I was trying to get a large group of very influential people on board with some changes, is what I did was I invited a great. I was at that time I may have been the co-chair of the Grand Round Steering Committee, but I invited a nationally recognized speaker whose care is in the care of people, of physicians. That's her life's work. And she spoke about physician suicide, and she showed a video of people who were survivors, who were physicians, and how that pulled at people's heart. Like, we think that the moral good is going to be enough, and yet there's 1,000 different things that are moral goods, and yet this is something big enough to matter and small enough to win. Like, we can do this. So what we did was we did that, and that was like this sea change in how people thought, and capitalizing on that momentum to get to where we needed to be. And that's like where those persuasion skills come in. Or in some cases, it can do something, I hate to say this, but it's true, is that what we can talk about is, well, what my concern that I have is the degree to which this could be a liability. And the reason why I'm concerned about that is because we all care about the people. Hands down, we care about the people.
Right.
What will also happen to the company, what will happen to the institution, what will happen to the school, what will happen to the organization, is that we will effectively lose we will probably lose staff who would leave because out of grief. We also will lose productivity. Because people, when they're grieving, they aren't able to do good work. I could say that when I was on call when one of my colleagues died, and and I was like admitting someone to the ICU, and in the morning when I looked at my orders, I had so many mistakes. The nurses and the pharmacists wouldn't let anything catastrophic happen. We know that, but people deserve better than not catastrophic. And I feel like I can say that because the part about like I made a lot of mistakes and I feel okay with saying it because we're supposed to be able to say that, but also because I know, because I'm a really good doctor and I have a good reputation, so I haven't had to worry about being able to say that. Not everybody has that, has that ability to, to have that confidence. But like when I shared that in different environments, people were like, oh, when I talked about the number of medical errors that I made when my colleague died and when I found out and I was taking care of critically ill patients. And again, the nurses and pharmacists had my back, but like, this is a liability for the company. There's a liability for the institution, and that sometimes can help people. Also, reputationally, this is an issue, and just finding out what matters to them, and then not overplaying it, but leaning into that, bringing in third parties to help us make our case for us.
Absolutely. So I want to thank both of you. We are at time. We will send out some other questions if people send them in. I really appreciate both of you taking the time, sharing your stories. I absolutely love to have conversations with others who are as passionate about this work. I thank all of you for joining, and most importantly, I thank the speakers for your contributions because they are incredible and they are life-saving. And so thank you both. I wish everyone a wonderful day. And again, I appreciate you. Take care, everyone.
Thanks.
Thank you. Appreciate you.